Welcome to IPOPI Hard Talks. My name is Martine Perjean. I am the president of IPOPI, and this is my pleasure to moderate this digital event.
Hello, I'm Dr. Nizam Alawi. I'm the chairman of the IPOPI Medical Advisory Panel, and I'm a clinician scientist working at the Necker Hospital in Paris, and I'm very glad to co-moderate this event together with Martine.
Thank you, Nizar. First, let me take a moment to thank our sponsor, CSL Behring, for making this event possible. Before we start, I will take a moment to briefly explain the IPOPI Hard Talk concept. With IPOPI Hard Talks, we will explore the complexity of our field with the help of two experts, a presenter and a challenger, who will both bring different perspectives. The presenter will give a talk, after which the challenger will open a stimulating debate. The theme today is PID and allergy crossovers, and the question may be, are allergies more common in PIDs than often thought? To engage this discussion, I am delighted to welcome our challenger today, Dr. Joshua Milner from the USA. Dr. Milner, you are a professor of pediatrics in the Institute of Genomics Medicine and the director of Allergy, Immunology, and Rheumatology at Columbia University Irving Medical Center.
Thank you.
And our presenter today is Dr. Leif Hanitsch from Germany. Leif, you are a senior consultant at the Institute for Medical Immunology at the Charité Hospital in Berlin, Germany. You take care of adult patients with primary and secondary immunodeficiencies and autoinflammatory disorders. Thank you for being here today.
Thank you.
Welcome to both of you, indeed. How will this work? Dr. Hanitsch will soon give his lecture. After the lecture, Dr. Milner will share his comments, and together they will discuss and debate this topic. During the presentation and the discussion between our two guests, you will be able to send written questions in the question tab. So let's begin. Dr. Hanitsch, the floor is yours.
Thank you very much. So again, thank you very much for the invitation to do that new or the first issue of that format, and thanks also for Professor Milner to join in to do that discussion together with me. During my presentation, I'd like to cover a bit of ground touching on the allergy spectrum and the immunodeficiency spectrum. So I think best to start with some basic pathomechanisms on what allergy is or atopic diseases, what is the concept of what we call type 2 inflammation. Then I'd like to highlight some of the most relevant pathophysiological links between immunodeficiency and allergy. I'd like to talk about two different clinical topics. The first one will be on atopic diseases in primary immunodeficiency, also talking on treatment and management approaches. And the other clinical topic will touch on the management of asthma in primary immunodeficiency disorders. And again, here we'll talk about two different treatment concepts, inhalative and also the use of biologicals. I'd also like to touch on what we call here the knowns and unknowns of parts of the immunodeficiency in the area of allergy. So what is the role of hyposensitization, for instance? Are there specific things that we need to consider when we try to use treatments that are established in other disease groups and apply them onto immunodeficiency disorders? And the last point is that I'd also like to talk on the role of biomarkers. So in atopic disease, and particularly in asthma, this is a very important field because we think that we can distinguish better which treatment might be suitable for certain patients. So let me start with a bit of a historical background. This is an image of the Emperor Augustus, who was meant to also suffer from allergic diseases, having here a bit of swollen and runny eyes. Then there is also this stamp from Monaco, which refers to the discovery of anaphylaxis as a major allergy complication. So it's not only a runny nose and itchy eyes, but that you can actually die from this very serious complication. When we talk about allergy, and Nisa already mentioned that I am only seeing adult patients, so I'm very happy that we have Professor Milner here, who's covering the side of the pediatric patients. We see a very distinct distribution of allergic symptoms. So it starts with the notion that real food allergy is really something that we only see in children. So we have many adult patients that tend to believe that they have a proper food allergy. This is most of the cases really not true, but it is something that is exclusively happening in children. It may also happen later in a stage, but it's much, much rarer. At the same time, allergic rhinitis and asthma is something that tends to develop later. You can also have young children, obviously, that develop asthma and can suffer severely, but by and large, this is something that's more on the spectrum on the adult patients. As general concept, when we talk about allergy, it is something where the immune system is responding inappropriately to a stimulus that is actually not meant to attack the body. So the immune system is having contact with this allergen, that's how we call it, and it gets sensitized. And upon re-exposure to that allergen, then the immune system is responding and is secreting factors that are very specific to that allergy process. And most of that is related to factors like IgE immunoglobulins, mediators like histamine, and we'll need to talk about mast cells as well, because they play a very crucial role in that. That is the vague description on the cellular level. Beyond that, obviously, there's a lot of things happening also on the subcellular level, and there are a lot of mediators, cytokines, that play a very important role, and that we will talk about that again, specifically when we talk about the treatment, because there are many treatment modalities that specifically target interleukin-5, interleukin-4, and other of those soluble factors that are involved in the process of allergy. Because this is a webinar that tries to link allergy or allergic diseases with inborn areas of immunity, I think it's important that we try to understand a bit better what the link is. And there are different parts that are actually falling together here. And the first example of that link is actually a disorder of the barrier function of the skin. So you can have mutations that not necessarily affect cells of the hematopoietic system, but you can also have mutations that affect the keratinocytes, so the skin cells, and that contribute significantly to the development of atopic diseases. And it's rather small, but maybe you can see FLG, that stands for filaggrin, which is probably the most prominent factor or genetic factor known to be associated with atopic diseases. And you also see SPINK5, which is, to my understanding, the most severe form of a very bad atopic disease, Compton-Lewis syndrome. And you have those factors that contribute also to the development of atopic diseases. Then it's also linked to the T-cell receptor repertoire. And the best example for that is a disease that we call Omen syndrome. So imagine if you suffer from a severe combined immunodeficiency where you don't have any T cells at all, then it's not possible really to develop a severe allergy. But if you have this leaky sort of phenotype and you still have a little bit of rest function, then this will lead to a skewing in the repertoire of the T-cell receptor, and you will not have this wide repertoire of different T cells, but you will have sort of an oligoclonal set of T cells. And this is contributing then to the development of the severe dermatological phenotype of babies that suffer from Omen syndrome, so mutations in the REG genes that are there to do the recombination in T-cell receptor and B-cell receptor alike. Likewise, it's very important to talk about the function of regulatory T cells. Regulatory T cells are there to sort of control the response of the T cells. So we want not to have that T cell response to be uncontrolled, to taking over, and we need specific steps to downregulate this response. And that is very closely orchestrated by a number of different factors. They are mentioned here. So FOXP3 is probably known to most of you. If you have a significant mutation there, you suffer from IPEX syndrome. And this is something that is also contributing to the atopic disease function. This is now putting together other factors that are contributing: cytoskeletal abnormalities, also called actinopathies, so diseases that contribute to the fact that the cells can no longer move normally, and that also the intracellular processes are not normally or functioning normally. The prime example for that would be Wiskott-Aldrich syndrome. We can also have altered cytokine signaling, which is depicted here. So we have these cytokines that are actually there to communicate between the different cell types. And once they're bound to the receptor of the surface, this information needs to be transferred to the nucleus so that the cell can adapt to this new situation. And during that process, we have kinases, JAK kinases, which we will talk about later as well. We have signal transducer and activator of transcriptions, which is also very important to talk about when we touch on atopic diseases and allergy and immunodeficiencies. And we have processes that can basically interfere with that products. This is a slide that was adapted from Josh Milner, who kindly provided that to us. And Josh Milner is basically the founder of the concept of primary atopic disorders. So PAD, for me as an adult physician, is more associated with primary antibody deficiencies, but for Josh, it's atopic disorders. And it's important to see that we have a significant overlap between these three categories. So we have primary immunodeficiency, we have these immune dysregulations, and we have the atopic disorders. And there are specific genetic defects that actually show that overlap quite nicely, and you will end up either more in the blue corner, the red one, in the green one, or you have a mix of all those three. Now, talking about allergies in patients with immunodeficiency, obviously we need to know, is that something that is affecting many people, or is it something that only affects a few patients? It is actually not an easy task to do good statistics on that. That is mainly because these registry data or other data are depending on, let's say, not very fine granular exams. So you will ask in a survey, for instance, do you suffer from allergy? And then patients might respond, yes, I do, but it's not always checked in the sense that they had a prick test, or that they checked for specific IgE, or that it's really solidly founded. But what we got a picture here from a recent overview that asked that question, and we have data in orange here from the US Immunodeficiency Network Registry, and we have another set of more than 8,000 adult and pediatric patients that were also surveyed from 30 different PID centers worldwide. And although they are a bit different, I think we get a clear picture that allergy is an issue in PID patients, and that it's mostly something that is playing in the area of bronchial asthma, BA, and atopic dermatitis. Anaphylaxis is something that's happening very rarely. I'm not sure where these 10% are really coming from. I think that's probably exaggerated. And also allergic rhinitis is probably more of an issue than it might show here. And then food allergy, again, is something that it's not of great clinical relevance in our patients. In the beginning, I said that it's important also to mention the concept of type 2 inflammation. So what does that mean? When we have an immune response, the T cells need to decide basically which type of response they're going to support. So depending on the antigen or the allergen in that case, the T cells will develop into different directions. And if we have allergic response, then we have a development of those T cells into so-called type 2 or Th2 response. This is basically orchestrated by specific cytokines. It's mostly interleukin 4, interleukin 5, interleukin 13, and it goes along with certain changes. And in this survey here that was also, again, done in the US registry, people were looking for a clinical vignette of a type 2 inflammation. And the most, well, the easiest way to do that is to look at two different parameters, and that is the level of immunoglobulin E, so IgE, and eosinophils as part of the white blood cells. And they found out that we have elevated levels of both IgE and eosinophils in all age groups. There is a tendency to have that occur more in the younger patients, but we see it in all age groups. And it basically affects around about 20% of those patients. So this is not a survey conducted by asking, do you suffer from allergy? But it is something that looks at lab parameters. And they even went a step further and tried to link that to the different disease groups that we know from the IUAS classification. So defects of innate immunity, complement defects, antibody deficiencies, and so on and so forth. And this is what you see here in the pie chart. And you have here in this mint color, maybe, these predominantly antibody defects, and they state here the number of genes or the names of the genes that they found associated. Now, this is not, well, it's not carved in stone, and we will learn later that specifically the penetrance of those mutations vary significantly. So you can have a mutation in BTK and never ever suffer from allergy, but you can have it as well. So just because BTK is listed here doesn't mean that this is always associated with atopic disorders. Atopic dermatitis, to come now from the more general concept of type 2 inflammation to a clinical image, is something that is seen in different disease groups. I think it's not surprisingly that you find those in patients that have immune dysregulation disorders or in patients that suffer from autoinflammatory disorders. But we see that also to a great extent in patients that suffer predominantly from antibody disorders, excuse me. And you can see here in that upper graph that you find these patients in those that suffer from a selective IgA deficiency. You see it in about 10% in patients with convariable immunodeficiency. You find it in patients with hyper IgE syndrome, and you see it in patients with Wiskott-Aldrich syndrome. Though I have to say, and I know that Josh will also ask about that there is a certain, well, it's a matter of definition. So is it okay to call it a atopic dermatitis when I have a known underlying monogenetic disorder? So can we still call it atopic dermatitis? Sometimes we tend to do this, especially when we want to use maybe off-label medication, but is it appropriate to do that? This is an incomplete list of those genes that are related to atopic dermatitis or to other signs of type 2 inflammation, eosinophils or elevated IgE levels. And again, they are here listed according to the link that I've been talking about between immunodeficiency and allergy, so disorders of barrier function, cytoskeletal abnormalities, T-cell receptor signaling, and so on and so forth. Let's now switch gears and talk about treatment. Atopic dermatitis is something where you need a lot of creams, tons of creams actually. This is what we have available depending on the severity of the disease. It's emollients added with steroids or not added with steroids. And this is something that we may discuss a little bit later. So that's the question. Do we provoke maybe a higher rate of bacteria or virus superinfections in patients that have inborn errors of immunity and atopic disorders when they are treated accordingly? So are actually those creams that contain steroids a risk factor? Are they contraindicated, or is it something that can be used without any problems? But we talk about that later. This is just a teaser, basically. If the topical treatment is not good enough, then obviously we have to switch to systemic treatment. And I will go a bit deeper into the concept of those treatments when we talk about asthma, but it's a step up concept basically. So if the baseline concept doesn't work really, and if creams don't really work, then you have to do something else. And in the end, you might also end up taking newer medications like biologicals or JAK inhibitors in order to treat these patients. There is unfortunately not a great amount of clinical data for the use of those treatments in patients with primary immunodeficiency. So we have cohorts, we have case studies that actually show as an example that the concept is working, but there are no randomized control trials, which is understandable because we're talking about patients with very rare diseases. I'd like to share as a proof of concept maybe these two publications that showed the effect of dupilumab, which is an antibody that is directed against the interleukin-4 receptor alpha. And by doing that, it's blocking the cytokines interleukin-4, interleukin-13. I've mentioned that these are the major cytokines involved in the type 2 response. And you can clearly see here in those patients that you not only have a downfall of certain markers that are involved in type 2 inflammation, interleukin-4, for instance, here, but you can also see that the clinical improvement is quite evident. And that is data that was conducted, and it's, I would say, clinical normality now in treating patients with autosomal dominant hyper IgE syndrome, so patients that suffer from STAT3 loss of function mutations. Another concept that is basically now recently has been included is the use of JAK inhibitors. These JAK inhibitors are important medications that have been around for quite a while. They were first used in order to treat patients with disorders of the bone marrow. Then it got expanded onto treating patients with rheumatoid arthritis, for instance. And now there have been a couple of clinical trials that showed very, very good response also in patients with atopic dermatitis. And just to make you a bit more familiar with this concept, as mentioned before, we have many different cytokines that do the communication between different cell types. About 200 different cytokines actually. Then they bind to receptors, and sometimes they share the same receptors. And then this binding gets basically orchestrated by a set of 4 different kinases that do phosphorylations. And then this is translated into the next step, where we have a use of 7 different STAT molecules, and STAT stands for signal transducer and activator of transcription. So you can imagine that when you have mutations along that line, either involving the receptor or the kinases or the STAT molecules, that you will have a much broader phenotype than when you have just a loss of one of those 200 cytokines, because it is affecting, as a matter of fact, many cytokines at the same time. This is basically, again, what happens. So you have the phosphorylation and you have a dimerization of the STAT molecules. It's mostly a homo, but it can also be a heterodimerization, and then it enters the nucleus and is actually then inducing the transcription of the genes of interest. These are the already approved indications. So we have rheumatoid arthritis. We've spoken about polycythemia vera, so the bone marrow disease. It's also now approved for atopic dermatitis. There has been a lot of talk about it in the sense of this hyperinflammation syndrome in COVID-19. It is something that we certainly will discuss later more about. Maybe now already at that point, I'd like to add a few points that need to be considered when we talk about the use of JAK inhibitors. JAK inhibitors are better than other biologicals in a certain extent, that they can also address the itching problem, because itching is something that apparently is, and Josh will know much better than I, through the function of interleukin-31, and which is addressed when you use JAK inhibitors, and which you cannot address when you just block, for instance, IgE to the same extent. You can use it both systemically and topically. We have to bear in mind, again, I'm treating adult patients, that it's not without any risk, and that we specifically have to be very careful in patients of older age and patients that have a history of cardiovascular events. Again, there are case reports and cohort studies for these patients, but there are no randomized controlled trials available for this treatment. Let's talk about asthma on the second part. So again, it's quite difficult to get here a clear answer on the prevalence. Again, it will depend greatly on the type of survey that you conducted. So there are differences ranging from more than 50% to down to 4%. Probably will be somewhere in the middle. there is interesting data coming from the group of Charlotte Cunningham-Rundles that was looking at other factors that are associated with the prevalence of asthma. And it is male, gender, it is reduced levels of IgE and IgM, and it's not related to the levels of IgE. Again, maybe CVID patients are not the best cohort to look at that, because by definition, most of those will not have very high IgE levels anyway. What is the treatment? Just very briefly, the baseline treatment is inhalative corticosteroids. Then it gets topped up with long-acting beta agonist or a muscarine antagonist. You may also use other modifying drugs. These drugs also can have side effects, and in particular patients that suffer from immunodeficiencies, they can be more severe. We can have here these oral thrush, so problems with candida. Obviously, we need to educate our patients about that, and we can advocate also the use of so-called spacer systems, which help that the corticosteroid particles are actually deposited in the lung where they belong to, and not so much in the oral cavity. We have different treatment options beyond these inhalative treatments, and there are a lot of new biologics available, and I think we will go into detail on those treatments again in the discussion part. The first treatment that was available is the Xolair or omalizumab, which is blocking IgE, and there is definitely evidence, and there is a reason for that in many diseases. It's not really the key player for other diseases in patients with immunodeficiency disorders. Then we have mepolizumab, which is blocking IL-4 and thereby acting against the eosinophils as well. And maybe as the latest introduction, we have tezepelumab, which is blocking the thymic stromal lymphopoietin factor, and which is approved for the treatment of severe asthma as well. Again, this is just a teaser, so I think during the discussion it might be interesting to talk about if all those biologics play a role also in our patients, if there are maybe some treatments which should be used with priority. The almost last point is touching on another approach, which is the hypersensitation. So there is a clinical paper, position paper, that states that basically the use of this immunotherapy, allergen immunotherapy, so hypersensitation, is a relative contraindication in patients with immunodeficiencies. That's an easy statement to do, because relative always means you have to look at it individually, and that's something that maybe Professor Milner and I can do in the next couple of minutes. We have different possibilities to do that. So there is the classical subcutaneous treatment. You can do a sublingual immunotherapy. And again, we need maybe to talk about if these hypersensitations work the same way in our patients than they do in other patients. Are they contraindicated, and can we expect the similar clinical efficacy? And the last point I wanted to touch on was the issue of biomarkers. So there are important biomarkers available in the diagnosis of asthma, for instance. So there is the exhaled nitric oxide, for instance. There is a lot of biomarkers that are related to eosinophils, for instance. The latest, I think, or pretty much the latest that I found is the eosinophil-derived neurotoxin marker, which is not widely available yet, but which seems to be a very promising marker, because it is something that you could also check in younger children. Meanwhile, the pheno measurements in young children is not really doable. We know in patients that do not suffer from primary immunodeficiencies that we have, let's say, a certain compositional combination of different biomarkers that will help us to predict if the patient may respond to a certain treatment or not. There's not much data on that in patients with primary immunodeficiency. So is it okay to check for blood eosinophils or IgE levels in serum? Is it something that we can ignore because it matters more about the IgE in the tissue? What about different cytokines or other factors? And that's, again, something that I would like to discuss now together with Professor Milner in the next couple of minutes. And the last point that I wanted to maybe close on is, again, going back to the initial slides, is that we should maybe no longer really consider inborn errors of immunity as a classic monogenetic disease and allergy as a classic polygenic disease, but there is definitely a spectrum. And I'd like to exemplify that with one discovery that is data from the so-called Leif study, which was really important because it tried to find out what are the mechanisms and what are the best management options to treat patients or infants that suffer from peanut allergy. And when they did a sub-analysis of that, they found out that there was a specific chromosome that was associated with a higher risk. And when they took a closer look of that, this is the so-called Manhattan plot. So when they took a closer look, then here, this is the chromosome 18 here, they identified that this was located to a gene called MALT1. And MALT1, for someone who's not familiar with allergy, was actually something that was coming from a complete different area, because MALT1 is part of a complex that you have seen before when we talked about the link between allergy and inborn errors of immunity, that is required actually to transfer the cell-cell interaction signal before it then activate the NF-kappa B signaling pathway. So we have, in immunodeficiency, we have it as an autosomal recessive disorder, causing a sort of severe, or at least leaky, severe combined immunodeficiency that comes along with high IgE levels and eosinophilia. And coming from the allergy part, we will see that these patients definitely have an increased risk for peanut allergy. Now, what's interesting for me in that aspect is primarily that we maybe need to think that many of the diseases that we now consider to be only relevant when they are biallelic, so when both alleles are affected, may still have some contribution even when only one allele is affected. And we might have been a bit too strict about categorizing our patients and saying that these monoallelic disorders may be not so relevant. So I'm very excited to see what's going to happen there in the future. So to come back to the major concept, I hope that I was able to introduce to you the concept of an overlap between primary immunodeficiency, atopic disorders, and immune dysregulatory orders. And also, I wanted to show you that the clinical phenotype is quite variable. And it's always difficult really to tell when should I think about another aspect. So do I need to think about the presence or occurrence of primary immunodeficiency in every patient that has urticaria or atopic dermatitis? Certainly not. I would say that it's always a combination of different clinical factors. So if you have a patient that has features of atopic disorders and you have other factors like immune cytopenia or lymphoproliferation or even lymphoma or an increased susceptibility against infectious diseases, then this is something that should really make you wonder if you're still only in one of those circles, or if you're now right in the middle of these three circles, and that you should go for genetic testing and see what the underlying problem could be. And with that, I'm happy to start the discussion with Professor Milner.
Thank you, Leif, for your broad overview and for raising so many topics for discussion. So, Josh, what would you comment on that, please?
I think one of the most important things to start with is that we need to use some term to refer to genetic diseases that impact the immune system. And so some people say IEI, and some people say primary immune disorders, PIDs. And Leif very nicely, described when you have a primary immune deficiency, which affects your ability to fight infection, versus a primary immune regulation disorder, which affects your ability to police your own immune system, and then the primary atopic disorders, which lead, to this predisposition to allergy. But it's very, very hard to ask the question about, how do we do this diagnose or manage an allergic disease in PIDs or in IEIs, because it's probably going to be quite different depending on what the underlying genetic problem is that's causing that IEI. We have to think about it that way, and really essentially never have the broad stroke of how sort of saying, well, if it's allergy in the context of an IEI, then it will follow this rule or that rule. It won't, because these are all quite different diseases. And even, let's say, if you picked people who had antibody deficiency and said, how do we handle allergies in people with antibody deficiency? It's all going to depend on what's really the underlying disease that's going on there that may significantly differ in terms of how you end up treating it. So I think that's probably the most important point I would make when we're thinking about this is, a question I always get is, well, if I have a weak immune system, how can it be that I'm having allergies, right? That's a very, very common question that we end up getting. And the answer is, well, very, very, very few people have such a weak immune system that they can't have allergies. Leif pointed it out when he mentioned the severe combined immune deficiency, but even there, you can have Omen syndrome where you do end up getting it in rare cases. In most cases, the immune system has a defect, and that defect can cause, a problem with fighting infection, but the very same defect could also cause a problem with policing the infection, policing the response, policing itself. And there are plenty parts of the immune system which work just fine and need to be policed, even in people who have an inborn error of immunity. So I think that's, really the most important underlying thing when we try to address how to think about something one way or the other, in the same way that when, I assume, Leif, when you see a patient with asthma who comes in and they're acting a little bit differently, and you're not even seeing them because they have a known underlying immune disorder, you just happen to see a patient with asthma, if they're acting differently, you start to wonder, what is the endotype of this disease? What is what is unique about this asthma, as opposed to just calling it asthma as though that has one term for every asthma patient you see? Is that how you usually approach?
Yeah, but definitely. And I think it's what's also important, maybe when you mentioned again that we need to look at these clinical phenotypes and to make the effort to understand what the underlying genetic is. I think to me it was quite quite important to see that many patients with so-called hyper IgE syndrome were treated with Xolair, which is directed against IgE molecules, and they did not really get much better. And this is because IgE in that sense is more like an epiphenomenon. So we see these elevated levels, but they are not really causing the problem. And we will just do basically cosmetics when we try to lower the IgE levels. So I'm totally in the same line as Josh, is that we really need to make the effort to understand what is the underlying genetic disorder, preferentially. Obviously, that's not always the case. And maybe working with kids, you have a much higher rate of genetic discoveries. But in adult patients, I'm happy when we get about 15 to 20% of our sequencing data back with a positive result. So it is still quite challenging. And I think we still probably miss a lot of things, even though we do next generation sequencing, but we just still not have yet understood completely what we need to look at. Right. So the MALT1 I think is a good example, because that would completely pass our view, because we would say, well, it's not important, because you need to have a defect on both alleles so that we can call it this is of significance. And that's something that we, as I said, we might probably learn a lot more from allergy or from other parts of medicine to come back to our patients and see, hey, maybe there is not only a hyper IgE syndrome due to a loss of function, but maybe there's also a STAT3 haploinsufficiency, for instance. I mean, there are some patients who have strange phenomena that were reported with fungal diseases, for instance. And I think we need to keep our eyes open on that and see where can we expand and detect more patients.
And actually, just one last point there, because I think, again, it'll illustrate it very, very nicely. So first of all, we do have some more severely affected patients with only one MALT1 mutation. And we think it's dominant negative in MALT1, and they have pretty severe allergy. It's not published yet, but the point is that when they had their sequencing sent, it was ignored because it was only one mutation in MALT1. And so the point is, absolutely, there's a spectrum. They don't have the infections that most other people have. One of the examples, another example that really illustrates this is people who are missing the IL-6 receptor or have a mutation in the IL-6 receptor. So there are very few. There's just a handful, maybe 10 people or 20 people in the world who've been reported who have complete loss of function of the IL-6 receptor. They get infections, bacterial infections, and they get eczema and high IgE and eosinophils and all those sorts of things, somewhat similar to STAT3 loss of function because it's in the same pathway. Remarkably, there is a very common variation in the IL-6 receptor that leads it to be just a little decreased in function. About a third of the population has this, and it is known to contribute to the risk for allergy, high IgE, and atopic dermatitis in the general population. They're all on one, on one area, on one level. But the point is, in both cases, it's reduced function of the IL-6 receptor. So, for instance, some people want to treat asthma or allergy by blocking the IL-6 receptor. This population is probably not the one for that, right? And so if you don't have those mutations, then you might think about, blocking the IL-6 receptor as an example. So that's just, that really sort of illustrates very nicely the continuum that may exist where there's still a focal problem in a gene, but the common underlying reason for why the allergy is happening then has relevance to how you would treat that particular patient. And so, Leif, I think you were, wondering about, let's say, managing atopic dermatitis, right? Or the susceptibility of people with atopic dermatitis to bacterial infections or viral infections if they have an IEI. And so, I really do want, absolutely, you can have bacterial superinfection and atopic dermatitis all the time, right? But when is it more problematic in people who have IEI, and should that change the way that you end up treating it? I don't think we've ever really seen much to say that using topical steroids is a bad idea if you have some host defense problem. Rarely has that been an issue for us. Certainly, as you pointed out, people who take inhaled topical steroids, they can get more oral thrush. Although I'm still not sure if anyone's actually done a careful study to show that the amount of inhaled steroids that a patient with IEI takes puts them more likely to get the thrush than others if they already have thrush, if that's their particular host defense problem. But you do have specific patterns of the way that atopic dermatitis looks. So in STAT3 loss of function or IL-6 loss of function or GP130 IL-6 ST loss of function patients, they don't get typical inflammation. And so you don't get the redness and even when they get an infection, they don't get the redness and the swelling that you typically expect to see. But they might get abscesses, which are very, very bad and not typical when you have atopic dermatitis. And so that pattern is different, and that does look that doesn't look like regular atopic dermatitis because the mutation in that pathway actually affects your ability to mount an inflammatory response. And in fact, in those patients, they have less anaphylaxis because the mutation affects the mast cells in a bad way, so that mast cells can't function normally, right? So they have an immune deficiency, they have increased IgE, and they have eosinophilia, and they have eczema, but they actually don't have anaphylaxis, and they don't have regular inflammation. It's different, but you're still treating it with the same medications that you would. The difference is actually, the only difference there is that those patients respond very well to taking bleach baths or vinegar baths, because the bacteria that's in their skin is really causing a lot of the trouble. And so by giving those folks vinegar baths, it helps a lot. There are other people, whether they have an IEI or not, you can have them swim in a chlorinated pool all day, every day. It doesn't help them with their eczema. But in that particular case, that's an example where it works. It's an example where the Xolair, Xolair doesn't work. You're absolutely right. The IgE in syndromes associated with high IgE, as opposed to the hyper IgE syndrome, since there are so many syndromes that lead to high IgE, blocking the IgE doesn't seem to do much of anything for most of their issues.
So what I would be interested, I raised that issue of the potential biomarkers. So here in our clinic, we obviously look at eosinophils. There are certain cutoffs that are required from the drug companies in order to use them. So you need to have at least more than 150 per microliter, but we know the higher, the better the immune response probably is going to be. There is a known correlation with the level of the eosinophils in the blood with the eosinophils in sputum, which again is the better, the higher the levels are. So we look at the blood eosinophils, we look at IgE where possible. As I mentioned before, in CVID patients, there's not much point in doing that. And we do the pheno measurements. Are there other biomarkers that you use on a regular basis in your clinic? Or what would you bet on which the new best biomarker is going to be?
Obviously, you're talking about for asthma in this case, or also for atopic dermatitis. I assume also, because there are certain atopic dermatitis drugs that you need to have certain biomarkers as well. Again, these are for the biologics. Absolutely, the IgE is completely confounded in a lot of these patients, but so is the eosinophils. So you can have high eosinophils in huge numbers of people with certain genetic defects that may not tell you anything about whether they're more allergic or not, or that they would respond to the medication or not. And in those cases, I really think to a large extent, the biomarker is, if you have it, that underlying genetic diagnosis, because that's what you're going to use to determine if you're in the right pathway for choosing whether it's a biologic or a JAK inhibitor or anything else like that, actually. What I will say is that we do use certain biomarkers, more in patients with IEI. We actually use serum cytokines in a certain way. So if we see very elevated IL-4 and IL-13 in the serum of a patient with an IEI, I would say blocking IL-4 and 13 makes a lot of sense. But if we see a bunch of other serum cytokines as well, or importantly CXCL9, which for a number of inborn disorders of immunity, including many explanations for common variable immune deficiency or antibody defects, you see an elevated CXCL9. If you see multiple cytokines being elevated in multiple pathways, that's actually where I would say there needs to be an intervention that suppresses the immune system. But where in the case of allergy, I would be careful about only giving anti-IL-4 or IL-13, because you might unmask other problems with policing the immune system by just targeting one piece of where there's a problem. If you see that there are lots of inflammatory things going on, that's where I would choose something more broad, like a JAK inhibitor, or if it's not available, something like cyclosporin or methotrexate or Cellcept even, depending, because especially in these IEI, where if the problem is generally with policing, then you may actually impair that policing even more by only blocking one part of what's happening. That applies in asthma, and that applies in and in atopic dermatitis as well.
Yeah, maybe Anissa, you would. Oh, sorry. Go ahead.
Can you hear me?
Yeah.
I have a slight. Yeah, my connection has been restored. Thank you so much, Leif and Josh, for this amazing overview. This is a very challenging and rich area of medicine, and coming back to a more basic clinical ground that probably is not also very easy to deal with on an everyday basis for the people who are listening to you. What do you think about do you think that PIDs are or might be underdiagnosed in patients with atopic disorders or allergic disorders in a broader sense? Because there are more people with allergies that there might be people with actual inborn errors of immunity. But how do we tip off our colleagues on what signs should be aware of? So we know about the warning signs in PID, but are there warning signs in allergies? And I know, Josh, that you coined the term primary atopic disorder, and that's very nice. And I think you work with it on it. But could you both let the audience know about what you think?
So I think it's actually both ways, right? So first of all, I do think that allergies sometimes can be under-recognized in someone who has an inborn error of immunity, because everyone's concentrating on the infection that could be horrible, the cancer that could be terrible, the profound inflammation or autoimmunity that's not related to allergy, and so we will often forget that if someone has chronic sinusitis, that we can give them all the IVIG they ever want, but if they are allergic to pollen, then they have inflammation in their nose, they're going to continue to have chronic sinusitis. So just as a small clinical point, I do think it's actually always important to look at it. And absolutely, you may end up finding that the skin testing is negative because they don't have IgE, but you still absolutely can get allergic inflammation in the nose with no IgE at all to pollens and things like that. So absolutely, that is a very important point to look on that. The flip side is what you're asking. That is why we came up with the term primary atopic disorders, because people tend to miss the notion that absolutely there could be a very clear underlying genetic reason for why someone has their allergic symptoms, and their then to get to the answer, at least from my perspective of what you're asking, is well, when does it matter, right? I mean, when do we care to look for a genetic reason when they don't have infections, let's say, or they don't have other autoimmune problems? It's just the allergic issues that are happening, but yet they're being underdiagnosed because everyone just assumes, well, if it's just allergy, then it's something else. And my general rule, I think the very easiest general rule is I would go to the senior clinician, go to Dr. Hanitsch, go to someone who sees lots and lots and lots of these patients, and say, whether I'm the patient or I'm the referring doctor, is this not typical for what you see? Is this more severe than most anyone that you see? It sounds very low tech, but it's absolutely, I find, to be the most useful way to say, hold on, this has been very difficult to treat. I've never seen someone who's allergic to vibration from the time that they're born. And that I'm picking that example because there is a genetic disease that just affects the mast cells that causes people to be allergic to vibration from the day that they are born in their entire life, right? That's an inborn error of immunity that's only causing allergic problems. That's something is very, very atypical. Those folks, I do think it's worth referring them for a full workup, or if you've noticed that it's atypical, you doing that full workup for inborn errors of immunity. And nowadays, most of the sequencing panels have a decent number of genes on there that could lead to allergic disease. to the exclusion, especially in a child, to the exclusion of other issues besides the allergic disease. I mean, in other words, you could have only allergic disease. So,
thank you for this very elaborate and really answer that broadens all the scope that we might encounter. And coming back to your point, I think, please listen to the patients, listen to the clinical symptoms, listen to the history, ask for medical history in the patient, but also in the family, and build a genealogic tree, a family tree. I think it's always very interesting and important. And then talk to your colleagues in allergology or immunology.
Yeah, I have a question from the field, and maybe a very simple one, but should all PID patients with allergy be jointly followed by an immunologist and an allergologist? Would it be an advice from, well, I think the opportunity to have both of you, of course, so I wish answers.
Maybe I can start. I think that question really goes back to where you live, right? So if you live in Italy, the clinical immunologist is an allergist at the same time. If you happen to live in Germany, it will not be that, because we don't even have clinical immunology as a subspecialization. We do rheumatology, infectious diseases, or whatsoever. And then it will certainly depend on what the clinical background of your treating physician is. In the US, I don't know, I guess it would also be more probably all in one hand. But yes, I think it depends very much on how safe and well taken care you feel in your PID center, if you think that this is covered sufficiently or you need an extra information.
Yeah, I would say that in the US, it's quite rare for the immunologist, even though we take the same board and we're the same specialty, quite rare for someone to properly take care of allergies and also properly take care of the complex immune deficiencies. In the US, though, also, if you do have a rare disorder, it's probably not a good idea to go to an allergist who's just in the community, because they won't be used to taking care of these complex things. So that may apply also, again, in other areas as well. But sometimes, yes, you need both.
Very, very wise answer. Thank you for that. Before we come to the end of the hard talks, I think, Leif, that you have prepared a quiz for our attendees. Would you mind commenting on that, please?
Yes. So there is the story that the first anaphylaxis ever to be recorded was of Pharaoh Menzies, who allegedly tried to embark and conquer the UK. And there is this image here, which basically tries to depict that. So you see the Pharaoh here, you see the wasp sting happening here. You see those girls mourning, and you see here allegedly those indigenous UK soldiers who are there depicted as well. So is this, do you think that this is evidence enough that actually Pharaoh Menzies died of a wasp sting, or can you discover on that image or picture maybe some factors that argue against this? It's a pity that you can't talk to me, but if you have spotted some things that seem peculiar or strange to you, then please type it into the chat.
Yeah.
And because we're already having 4 p.m., I think I might actually go ahead and show you those things that actually may be in favor of the story, but we also have a couple of points that argue against this. So we have here Big Ben, we have umbrellas, we have a cup of tea, we have the Tower Bridge, golf and football. So I think we cannot really trust this image, and we should rather go back and seek hard science and randomized controlled trials before we follow this idea that was presented here. And this, I think we expected that we would have more time to engage more with our audience, but I think it was me who spoke too long. Sorry for that. But next time, I hope we have more time to also get in contact with the audience. And still, I hope that everybody enjoyed our discussion.
Yeah, thank you so much anyway, because I think that we have really touched upon the complexity of our field, for sure. And thank you both for your discussion on the topic today. I think that we have some questions remaining in the chat. So Nisa maybe, or Leif, or Josh.
I'm writing a few answers.
Yeah, because it's important as well. So to Dr. Milner, thank you for being such a good challenger, and to Dr. Hanitsch for your very interesting talk and for all the answers you have provided. So we will now also share a short feedback form which should pop up on your own screen. Now it's done. It's very useful for us to know your feedback and hear from your comment to continue to improve this concept, which was the very first. Thank you to all of you for attending this first edition of the IPOPI Hard Talks. In a few days, you will be able to watch it on the IPOPI web TV, so this document will live. And don't hesitate to share it as much as you can. And many thanks again to our sponsors, CSL Behring, for making this possible. And see you in October on our next IPOPI Hard Talks. Thank you very much and take care.
Thank you.
Thank you. Bye.
Bye.